Suja Sukumar. Dr. Suja Sukumar, she is working as a consultant endocrinologist, Medicity, Cochin. She is a graduate from Tushar Medical College and she did MD Medicine from Coimbatore Medical College. She also done her MD in endocrinology from PGI Chandigarh. She has a special interest in pediatric and reproductive endocrinology. She has established first multidisciplinary transgender clinic in private sector at Kerala. She is involved as author in IPATH guidelines and IDEA consensus. She is a member of IPATH and WPATH. She is a recipient of A.V. Gandhi Young Researcher Scholar Award. She got state level gold medal in MD Medicine. So I request, ma'am, it's over to you. And she will be delivering the topic, Gender Affirmative Hormonal Intervention in Transfeminine Persons. So I welcome, ma'am. So over to you.
Thank you, ma'am, for that kind introduction. A very good afternoon to everyone. Hope you all had a very great lunch. So, can I have please the slides, please? Yeah. So, we already had a wonderful discussion on the endocrine management of trans masculine individuals. So Debmalia sir has covered almost very elaborately on the topic, and there are many common points as well that he discussed, which is very important with regards to the adverse events or initiation, checkpoints before initiation of hormone therapy. So I'll be mainly I'll be giving importance only to this topic proper. So what I'm going to discuss today is the management of individuals who has been assigned the gender at birth as a male, but their gender identity is female and they express femininity. So this is, I hope the slides are visible. Yeah. So let's have a case scenario. This is one particular individual who came to me around 5 years back. And she prefers to be called, her pronouns are she and her, and she was assigned male gender at birth. Now she is living in the society as a female for the past more than 5 years, and she wants to bring about more femininity into her expressions with regards to physical changes. That is why she came to me. So how do we go about in such a scenario? So as sir had discussed earlier, this is the WPATH criteria. We all follow the same protocol. So first of all, we need a referral or at least a clearance from a mental health provider, a registered mental health provider. So if patient directly comes to me, I usually refer to a registered mental health provider so that they can have adequate counseling before going into the hormonal therapy. And after having the counseling sessions, and if at all they have any mental health concerns, it can be adequately controlled. It doesn't mean that having a depression or anxiety is going to prevent them from getting a hormonal therapy. It has to be adequately controlled so that the mental health problems are not exacerbated by the hormonal therapy. So after that, and another important, the role of mental health provider is to document a persistent gender dysphoria so that the person doesn't have regret about this particular decision. And after that, and according to Indian guidelines, the age of majority is 18 years. So if it is before 18 years, we need a parental consent. Along with this, if it is more than 18 years, we can get an informed consent from the person. And then other things are not mandatory, like affidavit or 3 months of cross-dressing. Nothing is important. Only if these points are relevant, we can go about the gender-affirming hormone therapy. So usually we get such a certificate from a psychiatrist or a psychologist stating that this is a persistent gender dysphoria and that patient is fit to continue for a gender-affirming hormone therapy. And as an endocrinologist, our role is mainly to decide, like the first point I discussed, the criteria, is it well met? After that, it is also very, very important to inform that individual about all the possibilities, the adverse outcomes, and also, the limitations of the gender-affirming hormone therapy. Because usually there will be some unrealistic expectations, maybe because of the unawareness or something, that expectations, you should clearly inform them with regard to the timeline of changes or the adverse effect that they could possibly have in future. And importantly, whether the medical interventions that you are giving them, what all unfavorable outcomes that can be produced from this. Particularly with hormone therapy, what happens is the fertility potential can be adversely affected. So in a transfeminine individual, when you bring about testosterone suppression and you give estrogen, the sperm production will be adversely affected. So first of all, they should be informed about this, and they should be given the option of sperm banking, which can be done at a relatively very low cost these days, so that they can go about it. Whereas in a masculine individual, this could be difficult because the ovum cryopreservation and all, it is slightly costlier. And another duty of an endocrinologist is to not just to initiate the hormone, but continually monitor them, laboratory monitoring, the clinical monitoring while on hormones. These should be done, and at appropriate timings, whenever it is requested by your patient, you can refer them to the other departments, like surgical, when they are in need of, when they request for a surgical transformation, when the criteria is met, you can issue certificates and clearance certificates for these surgical interventions, or in between, if they have any dermatological needs, you can refer, gynecological needs. So all these referrals should be done appropriately. And also in between, the certificates that are required, like for example, if they want to register in the transgender portal, you need to issue some medical intervention certificates. That again should be provided upon the request by the patient. So usually in all adults more than 18 years of age, we get an informed consent from the patient. And informed consent, we have several formats, and you can modify it according to your hospital protocols. And this consent should clearly explain about all the possible outcomes of the intervention, and also the adverse effect on the fertility potential, and the fertility option should be explained to them. Now, the aim of our hormonal treatment is mainly to suppress that endogenous hormones. So in a transfeminine individual, it is the male hormone, which is testosterone, that is in their body. We need to suppress testosterone, and we need to increase the bring about or maintain the estrogen levels in target levels which will match with a cisgender female. So that is our aim, and so that the physical features will be aligned with their gender identity. That is, the feminine physical features can be brought about. So in adults, before going into this, usually we assess for any pre-existing medical conditions that could be exacerbated by your hormone therapy. For example, some people might be having unrecognized or undetected dyslipidemia, that is cholesterol and all problems, or undetected diabetes. So these kind of problems can be exacerbated, especially with estrogen therapy. There will be an increase in your triglyceride levels. Or some patients who are having a pre-diabetes, they might progress into a diabetes. So all these kind of medical conditions should be evaluated before initiating hormone therapy. And we importantly, some other the other hormone levels, which is important before initiating, that also will be done initially. Some viral markers in patients who are at risk for such diseases. And apart from this lab evaluations, what is more important is to counsel them, not just to initiate a hormone therapy. Most importantly, you have to counsel them with regard to the adoption of healthy lifestyle, because these metabolic health problems are likely to develop if when they are on continuous hormone therapies. So body weight maintenance or abstinence from substance abuse, all these should be counseled. And also if coexisting medical conditions are there, it should be adequately controlled. And then again, once again, you can remind them about the gamete preservation. And so what is the hormonal regimen that we use in a transfeminine individual? So first is, as I said earlier, we have to suppress the testosterone, innate testosterone. We have two options for this. The first and the best option would be to use a GnRH analog. See, this GnRH analog means it's a long-acting compound which we use especially in precocious puberty children to block the pubertal hormones. So if you give this compound like once in a month or a higher dose like 11.25 milligrams once in 3 months, you can adequately lower the levels of testosterone. But the problem with this is it involves a higher cost, and most of the people are not able to afford this particular molecule. So we have other options as well, where we use other oral anti-androgen medications, that is, which can block the testosterone. Such medications that is commonly used in India are spironolactone, which is known as Aldactone, which is it's not a costly medication, it's a relatively cheap medication. You can start it with very low doses like 50 milligrams per day, and you can gradually up titrate and go up to even 200 to 400 milligrams per day. And along with this, if a transfeminine individual is having concerns about the androgenic alopecia, which can occur in cisgender males, so if that is a concern, you can also add other anti-androgens like finasteride or dutasteride along with this. So this is how you suppress the testosterone. Now, unlike the trans masculine individuals where the Himalayas are told just to give testosterone, it will do both actions, suppress endogenous and bring about changes. But in trans feminine individuals, you need another medication to bring about the feminine features. Testosterone suppression is not just enough. So in that case, what you use is estrogens. So there are several preparations of estrogens available currently. Like you can have several routes as well. You can have oral estrogen tablets, or you can use transdermal preparations like patches or gels, injections. So several route of administration is available for estrogen, and there are different types of molecules as well. But historically, the problem with estrogen is it has been associated with an increased incidence of venous thromboembolism. If you look in literature, that would be the scariest part of using an estrogen. But all those data have been available with the equine estrogens like Premarin and all. With the advent of latest estrogens like estradiol valerate and 17-beta estradiol, this risk has come down remarkably. So I will come into the preparations. So So most importantly, we have to consider this in the Indian setting. See, all these molecules are available, but what all molecules can our patients afford? So consider a resource poor setting. In such setting, we can't advise them to take GnRH analog. So in such situation, what you can do is you can start with an anti-androgen like spironolactone along with or without finasteride or dutasteride, and gradually add the feminizing hormone therapy with estrogen. Usually we use oral estradiol valerate, and again gradually up titrating doses. And in addition to this, some ancillary therapies like laser hair removal, etc. might be required. I will explain that when we come to the timeline of changes. And in a resource-rich setting or ideal setting, what we would suggest would be a 3-monthly GnRH analog injections along with oral estrogen or transdermal estrogen. That would be our suggestion. So the estrogen preparations that are available, as I told earlier, if you look at that conjugated equine estrogens, it has a very high risk of venous thromboembolism, and that is why we don't prefer it these days. And very difficult to monitor the level of estrogen also with that compound, so we don't use it anymore. And what we use currently is the oral estradiol valerate. You can start it from 1 or 2 milligrams per day and gradually up titrate it to around 6 milligrams per day. And this will usually result in a target estrogen levels in your patient. And parenteral estrogen valley rate, actually previously it was available, then it became unavailable in India, but currently it is available in a few states. But in our part of South India, it is still not available, this parenteral estrogen, which should be given once in 2 weeks. That also is a good option. Another option is a transdermal estrogen, where you use a patch of estrogen which can be applied onto your skin, just stuck onto your skin. But it has to be changed every once in 4 days, this patch. So it is a wonderful option with very less risk of complications, but cost is again another problem with this transdermal estrogens. So according to the WPATH guidelines as well as the ESI guidelines, this is what we follow. Even in our country, we follow the same. That is, we give anti-androgens, either GnRH analog once in 3 months or spironolactone, titrating doses, and along with that estrogen. Now the role of progestins, because most of our patients, what they demand is they want the breast development. Because they attribute this breast development to femininity, so they want it rapidly. So what happens is this role of progestin is when, because progestins help in breast proliferation and it bring about such changes, but it doesn't lower testosterone levels. It has several adverse effects like weight gain or cholesterol problems and all. So according to the latest guidelines also, it is not generally recommended. Only if at all you have to use for specific indications like breast growth and all, you have to use the modern forms of progestin, which is the micronized progestins. Now, in whom we should not use estrogen? So that is when, suppose your patient is having a previous history of any thromboembolic events like stroke or something, or there is a cancer, neoplasm, which is responding to estrogen, like your breast or some cancers, then advanced stages of chronic liver disease. This hypertriglyceridemia is a relative contraindication. You can very well control it and initiate them on estrogens. Now, how long you should go on up titrating your medications, that is increasing the dose of this anti-androgens and estrogens, that is up to that level where you achieve the targets. So what is your target? You have to achieve testosterone levels to female ranges, that is less than 55 nanogram per dl, and also you have to achieve the estradiol levels, that is in the female range, around 100 to 200 picogram per ml. Now this is very important. As I told earlier, the unrealistic expectations associated with GAHT is one problem of future regrets. So the timeline of changes should be well explained to all of your patients at the initiation of therapy itself, that what they can expect as they advance through GAHT. So the earliest change that occurs is until 3 months of GAHT, they are not going to experience any change. Only after that 3 months, they might, in the next 3 to 6 months, they might start developing a breast bud, that is a small nodule underneath the breast, which gradually enlarges. So as Devmalya sir told, this is just like a puberty in a girl, where you develop the breast and over next 2 to 2.5 years or 3 years, you develop the complete changes in a breast. So that breast bud is the first thing that occurs, and another change that they can appreciate is a diminution in the body and facial hair that again takes several months. It may start with 6 months, that is the thinning of hair, not disappearance. It is just thinning of hair followed by some that frequency between the hair removals might change, get prolonged, and most changes complete by 2 to 3 years, complete or reach a plateau by 2 to 3 years only. There are other changes as well, like body fat distribution or some diminution in that sperm production, or spontaneous erections are reduced. So all these can be noticed over a period of time. So this is the average breast development at 1 year of GAHT. So that is why most patients, they want to undergo a silicone breast implant. They are not ready to wait until that 2 or 3 years until the breast development is complete. So hormone therapy definitely requires time to produce changes, and this is usually at 1.5 to 2 years of GAHT. Scalp hair regrowth is a good outcome of gender affirming hormone therapy, because most of the patients, if they haven't initiated this testosterone suppression by around that initial 20s to 30s, if they come late, most of them will have developed the androgenic alopecia. So at that time, when you give, when you suppress testosterone and give estrogen, usually there will be scalp hair regrowth. Like in our index patient, which I discussed earlier, we had a significant reduction, bringing down of that hairline. See, the estrogen therapy and this GHT is not free from adverse effects. I told earlier, the risk of venous thromboembolism, it exists mostly in literature. We don't come across it often, but there are others like dyslipidemia, insulin resistance and blood glucose problems, some increased levels of prolactin, and patients might tell you that there is some this milk production from their breast, gallstone development. Similarly, with spironolactone, there is hyperkalemia and hypotension. So you should be monitoring. This is our patient data, around 350 transfeminine individuals, in which the most common side effect they reported was salt craving. That is mainly because of your aldactone tablets, spironolactone. But other than that, venous thromboembolism is 0. And rest, everything else is very minimal, apart from that dysglycemias and dyslipidemia. So how to follow up these individuals? You should ideally monitor them every 3 months. Like for who are on spironolactone, you should monitor this serum potassium levels. And usually hormones can be monitored once in 6 months. And ongoing monitoring is very essential for everyone. This is very important to tell them. Not just initiation is important, monitoring is very important to prevent all the adverse events. And suppose your patient wants to go for a surgery in between while on hormone therapy. So a transfeminine individual, what we suggest is to withhold the hormones for at least 2 to 4 weeks, minimum of 2 weeks, and variable between 2 to 4 weeks, depending upon the comorbidities, before any genital major surgeries. And after surgery, if the patient is ambulated early, you can restart the GHT within 2 weeks. But most importantly, this is where most of the patients get lost to follow up from us. After surgery, they don't come back. They think their gender affirmation is complete. That is not so. After surgery, like especially after the genital surgeries, where the genital, the testis is removed, there is no hormone in the body. So it is very mandatory to continue the hormones of the affirmed gender, that is estrogen, at least to a minimum period where a cisgender women will have menopause. So around 50 years would be our target. At least until 50 years of age, they have to continue estrogen unless contraindicated. And after that, in between, if you want to, like if there are any problems arising out of GHT, you can shift to more safer options like transdermal estrogens. Like in elderly, this was what I was telling, till the age of natural menopause of a cisgender, you have to continue. And if even until 50 years, there are many people who don't undergo gonadectomy. So what to do in them? If virilization is the problem, you can continue anti-androgens. And if you want to continue estrogen, transdermal estrogen would be a safer option. And the other cancer routine monitoring, it is just like the cisgender population, like cancer breast, cancer prostate, everything is to be done according to the guidelines of the cisgender population. Another important thing is the bone mineral density. See, we know many people who undergo surgery, they stop everything. So this is going to affect their bone mineral density in a very severe form. Like there are people who underwent surgery at 25 years of age and they come to us at 40 or 50 years of age without taking any hormones in between. So this is going to adversely affect their bone mineral density. They may have osteoporotic fractures. So it is very important to screen them. See, a bone mineral density testing is not a viable option in our setting, resource poor setting for every people. So what you can do is assess the risk and follow them up appropriately. And usually I have a proforma and I follow up so that I don't miss any that follow-up parameters which are to be done. And this is one of my first patients who underwent gender affirmation. So I already went through this. I am not taking much time. These are the take-home points. It is always a teamwork. It is not possible to do a gender affirmation single-handedly. So multi-centric, multi-step protocol, and what we are doing is to help align the physical features with the gender identity. And according to the age of presentation, I haven't discussed anything about the adolescent hormone therapy because it is out of our time constraints. So according to the age of therapy, the choice of therapy actually varies, and timeline of changes is quite variable. One person having changes, breast development at 3 months doesn't mean that other individual will get the same effect at the same time. So it is very important to counsel all patients regarding the variable timeline of changes and prevent the unrealistic expectations, and the dose formulations which are given by them for an individual might be different for somebody else. So depending peers for their dosages is a bad trend to be followed, and ongoing monitoring is very essential. The clinical and laboratory monitoring is very essential for the successful outcomes. So with that, I conclude. Thank you all for your patient listening. And this is my team, and I would like to acknowledge my team of gender affirmation at this point of time. Thank you.
Thank you so much for sharing your ideas on gender affirmative hormonal intervention in trans-feminine persons. Now, floor is open for the discussion. If anyone is having any query, yes, please.
Nice presentation, Suja. Few doubts. In any trans feminine person, the SRS, that is before SRS, is the hormone therapy compulsory?
Yes, thank you.
According to the WPAT rules, because most of them are non-compliant with, at least in our part of the area, they are not compliant with the HRT. They straight away come for surgery. What should we do?
Sir, see, these protocols are set so that there won't be much future regrets with regards to therapy. So according to the WPATH protocol, for any non-SRS surgeries like your chest surgery, breast implant also, this hormone therapy is not mandatory. Just having clearance from a mental health provider is good enough to undergo any other surgeries other than the removal of gonads. But with regards to removal of gonads, since it's an irreversible procedure which is going to affect their fertility potential, it is always better to have at least 1 year of hormone therapy so that the person knows how to live with that physical features which are aligned to their gender identity. And so that 1 year of hormone therapy is actually mandatory in specific cases where the hormone therapy is bringing about any adverse outcomes or there are contraindications to it. The physician can take a decision accordingly. But otherwise, 1 year would be a better procedure protocol to follow.
Second thing is when they come for what you call breast or chest feminization, the one area where we lack much of advantage is the nipple areolar reconstruction. What hormone can help? How long we should give?
Sir, even after breast implant surgeries also, the hormones will continue to work and the areolar part will be enlarging further. So having a breast implant before hormone therapy is, it can be done, it is okay, and they can continue the hormones afterwards also. But if you take hormone therapy, estrogen and testosterone suppression for at least a period of 3 to 6 months, you will get adequate tissue on the chest, so that the implant placement would be easier for a surgeon and it will bring about more cosmetic results.
The breast tissue, maybe we methods, we add fat or we bring in subpatient. But the nipple areolar is the demanding area. What is the hormone which can really, recently I came across
estrogen can bring about very well changes. If you maintain the estrogen levels within that limits of 100 to 200 picograms per ml, it will gradually, but time is the most important factor here. So around at least 2 to 3 years of estrogen therapy is going to bring about a good areolar complex. Again, if the patient is not satisfied with estrogen, you can very well add some micronized progesterones to bring about,
progesterones can be added.
added.
Thank you.
Yeah. Can you give other mic?
Okay. Like I'm a community health person.
Okay, ma'am.
So whenever any person comes to us for health promotion or for preventive services, we do not call them patients. So if we could call these people as clients who are coming for these services, I think that would be better.
Definitely, ma'am. I take your point. It is very valid, and maybe because of our, we are used to this term, we are consciously, I'm giving an effort to change my vocabulary, but I'm really sorry if I have used the word. Maximum I use individuals with regards to transgender persons. Yeah.
Okay, thank you.
Thank you.
And second is, I fail to understand, like, what is the difference between a cis male and a male who is male by birth, like sex assignment is male, and gender is also male. Sex at birth, sex assignment is male.
Okay.
And further in life also it is male. So what is the difference between cis male and male?
It is cis male, not male. I mean, cis male, trans male. That is the only difference. It's the same.
It is the same.
It is the same. We are more used to binaries like male and female. That is why we are using the term male. Actually, all people who are born male at birth and assigned at birth and who continue to be male, they are cis males or males.
So for that matter, I am cis female.
Cis female.
Okay, thank you.
Yeah.
Hi, my name is Hayati. I'm a trans woman.
Hi.
Just want to understand one thing. It's regarding brain fog. So basically, brain fog. So basically, when trans people, especially trans women, take aldactone for longer period of time, basically there is something called brain fog where usually we can't think about doing things frequently just like any other people. We need someone's help to do something or depend upon any decision, any kind of decision. Like I being myself started my hormone replacement therapy in 2013 till almost 19 I took hormone replacement therapy, especially aldactone and estrogen. But what I see in those years is brain fog. Like I'm mostly dependent on my friends. It happened with the more dosage of aldactone. And what do you say about this? See,
actually, I am not very aware of this terminology like brain fog. But what I understand is any supraphysiological doses of any compound is going to create adverse events. So with aldactone, what we usually find is up to 200 milligrams per day. This usually doesn't create problems, but going beyond 200 milligram per day, you may get hypotension. Your BP might come low. That BP lowering can affect the blood circulation to every area, including your brain, and also it can affect in all these memory deficits or whatever you are telling, that fatigue and all those problems. So an ideal dosage it should not create problems, but if at all you are having such problems, it is always better to change the option of this anti-androgen. You can very well take a GnRH analog, which is completely safe and doesn't have much side effects. So that would be a better alternative for people who are having these problems.
I started with GnRH, but not everyone can afford for it every 1 month or every 3 months.
Yeah, 3 monthly injections would be the ideal thing for a GnRH.
Not everyone can
afford it. That is a problem. So aldactone in lower dosages should help you. It may not, because aldactone we use in even for other purposes. It's not just as an anti-androgen. It's a very good antihypertensive medication for cardiac purposes. Several other indications we use aldactone. So it is a good drug, provided we use in the appropriate dosages for each person, like weight based and all, we use it. It is not, and ongoing monitoring, it won't be much of a problem.
Me taking personally 50 to 100 mg per day in those years, whatever the issue I mentioned, it happened. It's less than 100 mg I used to take.
100 mg per day?
Yeah,
okay.
It used to happen.
it was happening.
Yeah,
so like your BP monitoring you were doing at that time, it was
not
fine?
Much, but it's normal.
Ideally, you should have checked your potassium, you should have monitored your blood pressure regularly, so that any like in between, if you are taking, like, increase the fluid content, you are taking more of some salted oral fluids and all, this problem might have minimized, you could have minimized, but then again we will have to look it into individually,
It's just
each
not
case.
my
Lot of people are having.
It's about my friends too, who are similar trans women.
And have you investigated? I think we should investigate further, like is there anything other than this aldactone alone which is causing this problem? So you should have reported, right? Reported it to your physician.
I did, but
because I personally haven't come across such a problem. My patients haven't reported it, but from now on I think I'll ask my patients about this particular complaint. Okay?
like I speak with 10 to 15 people, all of them complain the same, but not everyone knows the terminology just like I do.
Yeah, that is what I'll look into it, and sure.
Thank you.
Yeah, you can. Yes, sure.
So brain fog, I understand it from the perspective of psychology, like so it's confusion, disorganization and chaos when it happens in our ability to think. So I understand it from a perspective of psychology. I don't know if there is another perspective to it. So that is how I've understood throughout, since I knew the term. So it's more psychological from my perspective. Again, if anyone has to add to that, it's chaos, disorganization of thoughts, and we are confused. So basically, it just not happens with one person or another. It can happen with anyone. So how it goes.
Yeah.
I understand, but we all observed after starting taking aldactone. We all observed, like 15 of my friends.
Okay.
After taking aldactone, we started observing this. Not before that, not after that.
Okay, so actually that's interesting. That's an addition. I understand.
Exactly. I also knew
psychological,
Exactly. I also knew fog in relation to psychology only. So this is a new information, and definitely we will look into it. In the next cohort of patients, we can actually look upon it. But I haven't read anything in literature with pertaining to aldactone, such a symptom. Yeah.
Thank you.
Hi Suja. I think very nice.
Hi.
I want to ask you one question that before starting the HRT, we do the testosterone level. What will be the rationale of doing orchiectomy before, if there is a high testosterone level, not the full GRS or vaginoplasty, just removing one or two gonads? Will they decrease the dosage of the drugs, or do you think that can be added, or the medical treatment can suffice?
See, at least 1 year, what the protocol says, it should be there. So undergoing an irreversible surgery initially itself would not be a good option. Okay. It will definitely reduce the burden of that testosterone in the individual, but we can do that with GnRH analog as well. So 1 year, after 1 year, it would be a good option. Yeah.
Thank you, ma'am, for clarifying the doubts, and thank you all the participants. Now I request Seema ma'am to kindly felicitate our speaker, Dr. Suja Sukumar.